thankful to Dr. Arup for including me in his this prestigious master talk. I'm going to talk about strategies to optimize toric outcomes. We all know that in patients undergoing cataract surgery, there is preoperative corneal astigmatism of more than 1 diopter in 33%, more than 1.5 in 22%, and more than 2 in 8% cases undergoing cataract surgery. And the success of toric IOL implantation depends on accuracy of preoperative planning, intraoperative alignment, and postoperative management. And preoperative planning includes, like Dr. Arup very nicely pointed out, accurate biometry, corneal astigmatism assessment, ocular surface optimization, and please use modern calculators like Barrett toric, Kane toric, or the online calculators. And the patient selection should be very good. Avoid toric IOLs in irregular astigmatism. It is debatable in keratoconus, and always under-promise and over-deliver. And please also check higher order abrasions. So preoperative assessment includes thorough examination of lids. Please see whether there is MGD or blepharitis. If it is there, treat it. Dry eye ocular surface evaluation should be done. Optical biometry plus corneal tomography and macular screening by OCT should be mandatory. And precise biometry should include optical biometer, the latest ones, the swept source based, but don't be disheartened if you don't have them. There is no access to optical biometry. You can use immersion A scan, and you can have multiple keratometry readings, preferably on 3 devices where you are not getting consistent keratometry readings. Always, there are some acts of commission and omission which we should always be careful about. Like if there is, you're doing keratometry, you use appropriate formulas, inaccurate placement of IOLs, and acts of omission also have to be really given importance. Why do we get different readings with different keratometer? Because we know that cornea has a prolate shape, and if you measure closer to the center of the cornea, you're going to get higher readings, and if you are further away from the center, you will have slightly lesser readings. So integrated keratometry is important, where it has been shown and published that the median anterior surface keratometry value derived from 3 different devices leads to better accuracy. So we all are aware that 1 degree of misalignment leads to 3.3 degree decrease astigmatic effect, and 30 degree misalignment leads to total loss of toric correction. So if there is history of dry eye, please use lubricating eye drops 10 to 15 minutes before doing keratometry. Optical biometers are accurate, but if in doubt, you can, like I mentioned, take K from different instruments, compare both eye readings, and verify steep axis again in the topographic map. How much does astigmatism of the posterior corneal surface matter? It is important because majority of the people naturally have WTR, posterior corneal astigmatism, but it translates to negative WTR, so it becomes against the rule astigmatism. So that implies that if there is ATR astigmatism, we have to be more aggressive in treating this compared to with the rule astigmatism. Does the astigmatism measured in the manifest refraction matter? Conventional wisdom says to disregard, but it is important because it gives us some idea about the posterior corneal astigmatism, and then this value can be useful. So it is important to calibrate your machines weekly, because if you don't calibrate, you may land up with some errors. Then check the level, because if there is slight tilt of the head during optical biometry, this can lead to changes in the steep meridian axis measured using optical biometer, and steep meridian, it was found, generally shifted to the direction of the head tilt. Like here, once you corrected the head tilt, the axis changed from 72 degree to 82 degrees. That's a significant error which would have accrued if we had not paid attention to this. Remove outliers which are highlighted by the machine to improve measurement accuracy. Does ocular surface disease or dry eye affect biometry? Yes, it does, because it has been found that dynamic fluctuations in the anterior corneal surface can cause irregular astigmatism, Tear film instability can cause higher order abrasions, and poor repeatability of IOL power calculation can lead to post-operative refractive surprises. So please optimize your ocular surface pre-operatively by using tear supplements, anti-inflammatory eye drops, or if required, immunosuppressive drugs like cyclosporin, and treat blepharitis and meibomian gland dysfunction by the appropriate treatment if it is required. This slide shows that biometry done before and after dry eye treatment led to change of IOL from T5 to T2 just by simply treating dry eye of this patient, because he had significant dry eye, so we treated this patient for 1 month. Measurement errors can be in keratometry, can be if we perform keratometry, should be performed before putting any drops. It should be done on virgin eyes, and stop contact lens prior to the measurement. It is said for RGP to be not to be used for more than 2 weeks and soft at least 1 week. And in biometry, perform biometry before applanation and dilatation. But Dr. Arup showed that there is controversy regarding this, like he showed some papers from publications in the JCRS. Which IOL formula? I think I won't cover this because this will be covered by the subsequent speakers. So online calculators are refining biometry for toric IOL is equally important, and we should also calculate our SIA. What we can do is the data should be a data of 20 to 30 cases regarding incision location, incision type, incision size, pre-op and post-op K. 20 to 30 cases should be fed into this website, and that automatically generates your SIA. Effect of incision size in very small astigmatism does affect the choice of toric IOLs. And please compare the biometry of both eyes. If one eye is showing a toric requirement and other non-toric, you can recheck and repeat your keratometry and remove outliers in the measurements, if any. And so why is tomography important, better than topography? Because it measures posterior corneal astigmatism also, which influences which toric IOL model has to be used. Like in this case, initially it was showing 0.86 right eye WTR and 0.93 left eye. But once we incorporated the posterior corneal astigmatism, it shifted and the choice shifted from non-toric to toric. So pre-operative marking for toric IOL is important. It can be done with slit lamp marking, gas bubble marker, or you can scratch with gentian 26 needle and stain with trypan blue or gentian violet, or there are now smartphone apps also available. So what is better, manual marking or image guided? It was found that slit lamp marking method, about 28% of toric cases had alignment error of more than 5 degrees. So image guided method definitely helps, but if you don't have it, you can still practice your toric IOLs by refining the accuracy with the practice. So this is intraoperative overlay, and display, what you can do is display the toric IOL printout in the OT with steep axis. Per op cornea should be dry at the time of marking, and adequate rexis size with 1 millimeter overlap is there. So these are intraoperative strategies which should be practiced. So accurate axis marking, intraoperative abrometry if required can be done. Proper wound construction, and thorough removal of viscoelastic even from behind the IOL, and precise toric alignment is very important. And final confirmation is after pressurizing the anterior chamber, but not pressurizing, not over inflating, because that can also cause some rotation. Rotate the IOL clockwise till it is just 20 degrees short of the marked steep axis. Remove OVD thoroughly. Align the toric marking of the IOL to the cornea marking. Don't over-inflate the bag. So post-operative refractive surprises, these are some of the causes. It can be pre-operative, intraoperative, or post-operative. And the misaligned toric IOLs what it causes is, it causes you decrease in astigmatic correction, rotation of the astigmatic meridian, change of the refractive spherical equivalent, and the optical quality is also compromised. So early check within first week is important. Rotation management, if misalignment is more than 10 degree, please consider early surgical alignment, ideally within 1 to 2 weeks, and address the residual astigmatism and choose toric IOLs with proven rotational stability. So in summary, what I'll say is that pre-op work is very crucial, because well started is half job, half done. Optical biometry adds precision and comfort, but it is not indispensable. Conduct biometry measurements before applanation or dilatation. Calibrate your machines regularly. No head tilt on optical biometer or keratometer. Remove outliers and look keenly at the flags in the acquisition of the pre-op data. And consistent post-op evaluation of uncorrected visual acuity, refraction, keratometry should be done to optimize the outcomes. And please always under-promise and over-deliver, and explain the pros and cons beforehand to the patients. Thank you everyone for your kind and patient hearing.
Thanks a lot, Dr. Bhalla, for a very comprehensive